The exchange has a set of rules in terms of tiering of plans so you can compare them to each other. Right now, you go into the marketplace and it's a dizzying array. We know there's all sorts of experiments in terms of behavioral economics, and we know very well that the more options you give people, the harder it is for them to make a good choice. But by ordering it, by making it clear what are actually equivalent plans, you give people much better ability to make decisions. And if you do this right, the exchange becomes a way that you're actually regulating healthcare plans, because you don't just let everyone in. You do a request for proposal. People have to bid based on various elements to come in. And the reason they want to come in is that's the place where people who are getting healthcare subsidies get them. So that's the group that's guaranteed to be in there. Again, right now in HR 3200, we have a very robust exchange. From what I've seen of Senate Finance, they're thinking of it something more like e-insurance. That's a wide range, and where that comes out matters, and probably for price on this matters as much as having a public auction. The public auction, as part of this exchange, is important. I think Will's laid out some of the considerations of it. In order to work, it's got to be real, but it is a way that you can, by cutting down on those administrative costs that Jim Kahn will talk about in a minute, and not being in a for-profit situation, and having a large enough piece of the market, most importantly, so that you really can negotiate in a serious way in terms of the leverage vis-a-vis the providers, puts it in a situation where you can bring down costs and force insurance companies to compete, especially in those markets where you have one insurance company controlling a very large share of the market, or a small number of them. The next element on this, moving beyond, is the question of subsidies. And I'm going to go into this in detail in a minute, huge and vital part of the debate. If we're going to share risk, we're going to need to have an individual mandate, or something close to it. I think there are ways you can do it that you're not quite at an individual mandate, but you have to have something pretty close to it. Otherwise, if people wait and come in when they're healthy, that drives the costs up. When they're sick, that drives the cost up for everyone else. So part of sharing risk is getting everybody into the pool. Well, if you're going to tell everybody that they have to have coverage, you've got to make that coverage affordable. Public option is one part of that, but a big part of that is the healthcare, is the subsidies. The proposals right now have a range. Most of them expand Medicaid up to about 133% of the federal poverty level, and then have tax subsidies based on your income that go to various levels. And again, I'm going to come back to that in detail, because I think it's an essential part of the debate right now. Well, along with shared risk is shared responsibility. I already mentioned the individual mandate and why we need an individual mandate. The second part of that is employer responsibility. Two of the three main bills out there include a play or pay requirement. Basically, the idea is employers have to either provide coverage or pay into the exchange. Well, why do that? The reason you do that is, if we increase our subsidies for individuals who are in the exchange and say, okay, if you don't have coverage, you can't afford it, we're going to subsidize your coverage if you're low or moderate income, then employers who employ large numbers of people who are low and moderate income would do best by ceasing to offer coverage. Because in effect, their workers then would be able to get subsidies. Now, we assume if you're above the minimum wage, most economists will argue that the price of healthcare gets passed on to workers in terms of lower wages. So what an employer should do is look at what is it that it'll cost the workers to get coverage in the exchange with their subsidies, and how much would I have to give them a raise to make them whole compared to if I give them coverage right now. Well, if you do not have any employer requirement, then it makes a lot of sense, and looking at the kind of subsidy levels out there, it makes a lot of sense for employers to drop, if your average member of your workforce is in a family under about 300% of the federal poverty level, you should probably drop coverage. In the abstract, as society, do we care, should we care if it's provided by employers or if it's provided by the taxpayers? You could argue the answer to that is we shouldn't care. Except one, it makes it a lot more expensive to do. That means you have to raise more taxes, and we know the debate right now. That's a very difficult thing to do. Basically, you're taking something that's been done off the federal books, putting it onto the federal books. That's a very politically difficult thing to do. But also, we do have to worry about competitive effects between firms. What the employer requirement does is basically levels the playing field. It says all employers have to meet some kind of standard, and that standard works both in terms of some kind of standard. So basically, people are not competing primarily on or heavily on how much they're providing in health insurance. The other place that leveling the playing field plays in, and Larry Summers has made a big argument about adverse selection. Some firms provide coverage and some don't. Then sicker workers should seek employment with those firms that do provide coverage. So that has impacts on the risk pool. And we know a number of firms have dropped coverage for part-time workers for this very reason, because it's clear that their risk pool has changed when they're doing things that their competitors are not doing. When some firms provide coverage and some don't, in the current situation, people without coverage go out and they get care through hospitals, uncompensated care that gets passed on into the rest of our premiums, estimated to be somewhere between 3 to 10% of our premium costs. And then the other method of cost shifting is just simply dependent care, right? One employer doesn't provide coverage, another employer pays for it through the spouse. Okay, so we agree that we need to have some kind of employer requirement. Then there's this can be done in any number of ways. San Francisco is a per hour requirement. The House bill, HR 3200, is a percent of payroll. It's basically you have to either provide or pay 8% of payroll. So the big objection to an employer requirement is, well, won't this raise the cost of doing business and will it cost jobs, right? So the argument there is basically the same argument we hear around the minimum wage, and there's actually quite a bit of literature on the minimum wage. If we look at and assume that above the minimum wage, the costs of healthcare are ultimately passed on to the worker, then the cost of doing a healthcare requirement is basically the same as a small increase in the minimum wage. The effects should be quite similar, and the minimum wage literature, more and more I think is a consensus building. There's still some debate that the minimum wage has had no measurable impact on employment for a